Great, thank you. I'll just try and share my screen. Hopefully this works. Can you see my slides?
Not
Oh,
yet.
yeah.
Oh, coming up. It's coming up, I think. Oh, yes, we can see.
Perfect. All right. Good morning or good afternoon, depending on where you are. Thank you, Dr. Cordina, and to the Fontan Registry in general. Thanks for inviting me to speak and for all the good work that's done through the registry. So I'll be talking about the Fontan circulation. So a bit about the principles behind why patients end up following a pathway that ultimately leads to a Fontan circulation. I'm just going to move this box out of the way so I can see properly. Perfect. So I have no disclosures. So an overview of my talk, I'll be talking firstly a little bit about the normal heart, because I think to understand why patients have single ventricle and why we proceed towards a Fontan circulation, you need to understand how a normal heart works and is structured. I'll talk a little bit about just an overview of congenital heart disease in general, and then more specifically about single ventricle congenital heart disease. Principles of surgical intervention in single ventricle patients, and then I'll talk about the Fontan circulation itself. So for those of you who don't know, so this is what a normal heart looks like. So normal heart has 4 chambers. There's 2 at the top of the heart that drain blood from the lungs and from the body. There are 2 pumping chambers at the bottom, the left ventricle and the right ventricle. And they have different roles in the normal heart. The right ventricle receives blood from the body, which is more blue blood, and it pumps that blood towards the lungs to get oxygen. That blood returns being more pink and saturated in oxygen, returns to the left side of the heart, and the left ventricle does the heavy work pumping that blood around the body. In the normal heart, there are also 4 valves. So these valves separate the chambers, and the primary role of all the valves is to open freely to allow blood to pass through, and then to close in between to stop blood leaking the wrong direction. And so here's an example. This is an angiogram of a patient after having a heart transplant. And so this is a catheter coming down from the neck vein and sitting in the SVC, the vein that drains blood from the upper body, and injecting dye in the SVC, which really shows the full circulation of blood through the right heart, through to the lungs here. And then the blood passes through the lungs and returns to the left heart here, and then goes towards the body. So this is the right atrium, right ventricle, lung arteries here. Blood returns to the left atrium, left ventricle, and ultimately goes towards the body. So that's what a normal heart looks like. So what about congenital heart disease? So congenital heart disease is essentially a problem with how the heart is structured or how it's put together, and generally develops in the early stages of pregnancy. It affects about 1 in 100 children, so it's relatively common. Essentially, there can be various issues with how a heart lesion can form. And people might often ask what can go wrong with the heart, and really pretty much anything you can imagine. So it could be a problem with any of those structures that I mentioned, and some of those, in fact, a lot of the time, those are not very significant problems, and most don't require any intervention. And then the lesions that are more significant, most can be repaired these days with different approaches. So I'll just go through an overview of some of what those can be. So there can be a problem with how one of the heart valves or several of the heart valves are put together, which could mean the valve is narrowed, like this example of narrowing of the aortic valve, which sits here. So that's called aortic valve stenosis. Or it could be a problem with leakiness of one of the valves in the heart. Generally, valve problems that affect children, generally we can repair those either with a surgical operation, with repairing or replacing the valve, and also sometimes we can do catheter interventions to improve the function of the valve or also replace the valve. Quite often there can be defects or holes that develop inside of the heart, and so these can occur particularly between the walls separating the 2 chambers. So for example, on the left here, a hole between the top chambers of the heart in the wall is called an atrial septal defect. Quite commonly, patients can have holes in the wall between the bottom chambers of the heart. These are called a ventricular septal defect. And all of these holes can come in different shapes and sizes and locations, and some patients can have many holes. Often they don't need anything done about them. But again, if they're more significant a problem, we can usually deal with those these days with an operation or sometimes with a catheter procedure to close the hole with a device. There can be more complex issues with how the heart is put together, where there's abnormal connections. For example, here, this is called transposition of the great arteries, where the great vessels, the aorta and the lung artery, actually come from the wrong side of the heart. So the aorta here normally would come from the left ventricle, but in this example, it arises from the right ventricle. And there can be, again, a various mix of different lesions where there's abnormal connections, but for the majority of these patients, we can also repair these with heart surgery, often in the early stages of life. But what do we do if one of the ventricles, the muscle itself, is too small? And this is really where single ventricle anatomy comes in. So there can be more complex issues with heart development where, for example, here on the left, all of the structures on the left side of the heart are underdeveloped. And so this is called hypoplastic left heart syndrome, where all of these structures, the valves, and particularly the muscle, the ventricle here, is really very small compared to on the right side. Alternately, the problem can affect the right side of the heart. This is an example of someone with something called pulmonary atresia, where the lung pulmonary valve here doesn't form properly. And again, in this case, the right ventricle is underdeveloped. And this is a more complex problem where we can't just create more heart muscle to have two ventricles that work. So in these examples, these patients would be defined as having a single ventricle because really there's only one good-sized ventricle that's effective at pumping blood to the places it needs to get, and we can't just create more heart muscle. Occasionally, patients can be defined as having a single ventricle, even though they can have two good-sized ventricles, and that can sometimes be the case if there's complex connections with these valves in the middle of the heart. Here's an echocardiogram of a baby with hypoplastic left heart syndrome. So it's quite obvious to see these are the structures on the left side of the heart over here, and these are the structures on the right side of the heart over here. I'll let that play. This is a right ventricle, which is a normal size, and it's quite obvious to see that this left ventricle over here is really very small and far too small to sustain blood flow around the body. So if we cannot repair the heart, then we have to find a different solution. And in patients with a single ventricle, they only have one pump that needs to do all of the heavy lifting that two ventricles would normally do. And so we can't simply repair one of the problems with the heart, and we need to do what's called palliative procedures, where we don't fix the underlying problem, but we try and manage with it as best we can. And so when we think about a surgical approach to try and manage a patient with a single ventricle, there are a number of objectives we need to try and achieve. Firstly, we want to think about finding a reliable source of getting the blood flow towards the lungs. We also need to think about a reliable source of getting blood flow through the body. And then, because there's only a single ventricle, we need to find a way to have that blood returning from the body and from the lungs, the pink and the blue blood. We need to find a way to have that mixed together within the heart because there's one ventricle doing all of the pumping. And lastly, with all of the connections in the circulation, we don't want to have significant narrowings. So if there are, we need to try and find a way to manage that. So generally, for patients with single ventricle anatomy, we perform surgical palliative procedures because we're not fixing the problem. And for most patients, these involve 3 stages of repair. In some patients, they have less interventions and others have more. Being interrupted by my dog, so I don't mind. Most patients have 3 interventions. We cannot perform all these in one single operation in a newborn because of other issues with resistance in the lungs and also to improve surgical outcomes. So the surgical stages, generally there are 3 stages for most patients. The first stage is usually in the first week of life. The second stage is between around 3 months to 12 months. And the third stage in most patients is between 3 to 5 years. Again, in individuals, this is tailored and sometimes there are variations and some patients don't go through all of these 3 steps. As I said, some patients do have additional operations if necessary, and in most patients, they'll have at least one heart catheter procedure performed in the first 5 years of life. Some have many, and then patients will usually have several others performed down the track. The first stage intervention is something often called the Norwood procedure, which certainly applies to patients with that previous lesion I showed, hypoplastic left heart syndrome. Again, depending on patient anatomy, sometimes there's a slightly different approach. Usually this is performed in the first week of life, and the Norwood procedure involves placing a surgical tube here, a Gore-Tex tube, between the body artery and the lung artery, and that's the source of blood flow towards the lungs in patients with hypoplastic left heart syndrome. There are other parts of the repair performed where we create the right ventricle being the main source of blood flow getting out towards the body here, and we free up connections within the middle of the heart. After this operation, children still have lower than normal oxygen saturation, usually between about 70 to 90%. Here's an angiogram illustrating that. So this is a catheter coming up from the leg artery up through the aorta, the main tube that sends blood towards the lower body. And the tip of the catheter here is positioned at the origin of that shunt that I showed in that previous diagram. And so there's an injecting dye here in this artery. If I let that play once more, this is the shunt, the tube here that connects directly towards the body arteries to the lung arteries to supply blood flow to the lungs. In most patients, the second stage operation is the BCPC or bidirectional cavo-pulmonary connection, also sometimes referred to as a Glenn operation. This is generally performed between 3 to 12 months of age. And with this operation, the primary change is disconnecting the neck vein, the SVC, disconnecting that from the heart and connecting that directly towards the lung arteries here. And then that previous shunt that I showed on the previous image is removed. With the Glenn operation, now patients have passive venous flow. The blood draining from the upper body passively flows through the lungs, and the blood from the lower body continues to return up to the heart as it previously did. After this operation, children generally have an oxygen saturation still between around 70 to 90%. Here's an example of that. So this is again an angiogram. This is a tube coming down from the left side of the neck and positioning one of the upper body veins, and then some dye is being injected at the start of this injection here, and that drains through this SVC here, which connects directly to the lung arteries, and that blood travels through the lungs to get oxygen and then returns back to the heart here to pump towards the body. The final operation in most patients going down this pathway is the Fontan operation, and that was first performed by this man, Francis Fontan, who was a French cardiologist and a surgeon, and he first performed the operation in 1968. Our approach has changed a little bit over the decades, and the detail of how we perform this operation has changed, where now most patients would receive this type of Fontan. It's called an extracardiac Fontan, extracardiac conduit Fontan. But essentially, the principle of the Fontan operation is to now remove the IVC, the lower body vein, remove that from the heart, and also find a way to direct that blood flow up towards the lungs. And so after the Fontan operation, now all of the venous blood draining from the upper body and from the lower body would make its way towards the lungs. Some patients do have a little hole created here, which is called a fenestration. And that means that it is a small connection that allows some of the blood that would go to the lungs to bypass the lungs and still go directly towards the body. There are benefits of the Fontan fenestration in the early stages after surgery, but the compromise is that patients have a slightly lower oxygen saturation. So depending on the size of presence of fenestration or not, and the size, patients will have an oxygen saturation usually somewhere between about 85 to 95% after the Fontan operation. In patients with no fenestration, usually the saturation is in the 90s. Here's a spinning 3D rotational angiogram, which I'll stop in a second, which shows that Fontan connection. So let me just advance here. So this is blood returning from the lower body that's coming up through that conduit and coming up towards the lungs. And then the SVC connection is coming down here and also connecting towards the lungs. So now all of that venous drainage from the body connects to the lung arteries. And here's some angiograms that show the same thing. So the image on the left is a catheter coming up from the leg vein, which is positioned up in that SVC, that vein draining from the upper body. If I let that play again, and that connects directly towards the lungs and flows through the lungs. And then on the right image, this is the same patient with a catheter in the lower body vein, the IVC, and that's also connected up towards the lungs here to get oxygen. This patient does have a fenestration or a hole created in this region here. So some of that blood that's coming from the lower body does bypass the lungs and come through here straight towards the heart and go straight back towards the body. That's what the Fontan connection or circulation looks like. In patients with a Fontan circulation, as many of you would know, there's important long-term monitoring required because this is not a normal pathway or a normal connection. And so for all of these patients with a Fontan connection, in those veins that are connected towards the lungs, the blood pressure is abnormally high. And that's just part of the consequence of connecting these vessels directly towards the lungs. And so that higher venous blood pressure causes back pressure on all organs in the body. And that can particularly have significant impacts on many organs, on the liver, on the kidneys, on the gut, and on the lungs. And so for these reasons, it's important to screen for problems that might develop in those organs and try and deal with them as best as possible. Patients can also have a limited ability to increase cardiac output because, again, there's that one pumping chamber, that one ventricle that's relying on pumping blood all the way through the body and then all the way back through the lungs before it gets back towards the heart. And particularly that blood flow through the lungs is a source of significant resistance that can limit the ability to increase blood flow through the body. And also, patients with a Fontan circulation can have problems that can develop with the heart itself, with the heart function, or heart valve problems. And so for all of these reasons, patients do need close surveillance and intermittent monitoring of function of all of these organs. And some of the time I come across patients like this who need a heart catheter procedure to better understand their circulation, understand if there's any issues or narrowings in these connections, measure that resistance of blood flow getting through the lungs in particular, and try and see if there are any issues that can try and be dealt with to optimize the circulation in the long term. So in summary, single ventricle palliation usually evolves towards a Fontan circulation. The Fontan circulation is an abnormal pathway of blood flow, but it provides the best long-term outcomes in patients with complex heart disease, and long-term monitoring is needed of all of these organs to try and identify and treat problems early on. Thank you.
Thanks so much, Cam. So there's a few families on the line whose children haven't yet had a Fontan circulation, and I think also people who have a Fontan circulation will be interested to understand. Somebody's said to us, their daughter's 2.5 and they're currently sort of pre-Fontan, and there's discussion about next steps and that she's going to go to Fontan soon. And currently her oxygen saturations are starting to fall below 70. And she said, is that normal? Can you sort of talk us through what your thought process is as a pediatric cardiologist and decision-making at this point?
Yeah, so as in my talk, I tried to be pretty broad in the description of how we manage these patients, because the reality is there's a huge variation amongst individuals in lots of parts of anatomy, timing of surgery, what surgery we do, and exactly how we manage the complexity of what is single ventricle anatomy and physiology. We have ideals in our mind about what we would like our patients to, how we'd like our patients to be and behave and how we'd like their physiology to be, but it doesn't always add up to be exactly what happens to the individual in front of us. And there's lots of factors that contribute to that. So it's certainly hard to explain for this individual. I think we usually, ideally, would prefer patients with a Glenn circulation to have oxygen saturation above 75%. But we do know that in everybody, those saturations will decline as children get older. And as they demand more blood flow around their body, that's why we do the Fontan circulation, is to increase that venous return from the lower body to also get to the lungs and bump up the saturations again. So we know in all patients, the saturations do decline in those years between the Glenn operation and the Fontan operation. The timing of that is really hard to predict in an individual. And sometimes we do need to react to patients who have lower oxygen saturation than we might like. Part of that might be investigating to see if we can find a reason why their saturations are lower. And then sometimes we do need to choose to do an intervention in the interim before the Fontan circulation, or doing the Fontan operation earlier in some patients to try and deal with the problems that we encounter. So it's a really complex decision-making situation that usually involves multidisciplinary teams. And when we have these challenging patients who aren't following the exact pathway that every other patient would like to follow, we need to react to that.
Yeah. And so it's weighing up lots of factors, and it's important, if you haven't let your team know about that change, do let them know.
Yeah, I mean, I think every cardiologist manages their patient a little differently. For me, if I felt comfortable with the scenario, it might be a situation where we continue to monitor. But certainly, if individuals feel uncomfortable and there's still a big gap from that time frame where we usually think we want to think about the Fontan operation, which in most centres in Australia is after 4 years of age, then sometimes we bring those patients to our group discussion and seek opinion from others and try and weigh up, are there any other tests we can do? Are there other interventions we should do to try and optimize things?
And could you explain to people why we do the fenestration? And also, I think it would be important to acknowledge that different centres do things a bit differently too.
Absolutely. With a lot of congenital heart disease management, we have limited evidence. We rely on the best evidence we have, but for the most part, the evidence is limited for a lot of the things that we do. And so the fenestration came around because we knew that the outcomes early after the Fontan operation, particularly patients can have a lot of fluid buildup around the lungs, and sometimes in the immediate stages after the Fontan operation, patients can have poor outcomes with a lot of fluid buildup and drainage and needing drains in for a long period of time. And so the rationale for the fenestration is to try and offload some of that blood flow through the lungs to perhaps reduce the pressure in the Fontan circulation a little bit, to perhaps improve early post-operative outcomes. It is controversial and it's very centre specific, and there are some centres that fenestrate almost every patient. There are some centres that fenestrate almost no patients, and there are some centres that do a bit of everything. And there are pros and cons of both approach. So it is in some ways driven by the centre that the patient is having the surgery in some ways driven by the patient anatomy and the physiology. And I think everybody in the team often has some say in that. So there are pros and cons of all the things that we do in terms of our interventions, and the fenestration has some potential benefits and some potential downsides, cyanosis, and perhaps slightly higher risk of having stroke in the long term because of having that connection still from the body vein directly towards the body again.
Yeah, and then and oftentimes we go up and can close it with a little device.
Yeah. Exactly. So as interventional cardiologists, we often would come back in a patient who might have had a fenestration, particularly if their oxygen saturation is a little bit lower than we would want. Then we would often take that patient to the cath lab, assess their hemodynamics, try and see if they seem suitable for fenestration closure. And if they do, then we can put a little device in there and close off the fenestration, and then it's closed.
Great.
Yeah.
Thank you so much. Thank you for spending some of your Sunday with us. We really, really appreciate it.
No worries. Thanks for inviting me.